All right, guys, why don't we go ahead and get started? Let's begin with some introductions. Katie, would you like to start for us?
Hi, can you hear me?
Yes, we can.
Great. I am Katie Chasson Downs. I am work with Chestnut Ridge in Morgantown, West Virginia.
Perfect, thank you. And Douglas?
Yeah, Douglas Harvey, case manager for WVU Medicine.
Thank you. And we got a chat in, Cheryl Harmon, case coordinator with WVU PC Charleston. Thank you. Tracy Sun, would you like to introduce yourself?
Yeah, I'm Tracy Sun. I'm a coordinator for the West Virginia Practice-Based Research Network.
Thank you. And Jennifer Boyd, would you like to introduce yourself?
I'm Jennifer Boyd. I'm a physician assistant with New River Health Association.
Perfect, thank you. And Dr. Zhang, would you like to introduce yourself?
Yeah, I'm Wang Hongzhen. I'm one of the psychiatrists at Chestnut Ridge Hospital. I run a dual diagnosis unit, so I also manage a fellowship, addiction medicine fellowship program.
Perfect, thank you. And Dr. Hirschler?
Yes, hello, I'm Jeremy Hirschler. I'm an addiction psychiatrist. I work for WVU, and usually I'm at the Lakewood Center, but I'm at Chestnut Ridge today.
Perfect, thank you. Tony?
Hi, Tony DiCiacchio, family nurse practitioner with WVU School of Nursing, and I work with the team at Chestnut Ridge.
Thank you. And let's see, Laura Simmons, would you like to introduce yourself?
Hi, Laura Simmons with Minnie Hamilton Health System, case manager for their MAT program and behavioral health.
Perfect, thank you. And Dr. Bao, would you like to introduce yourself?
Hey, this is Dina, Charleston Division for WVU, sorry.
Perfect, that's wonderful, thank you. And Andrew?
Yeah, I'm Andrew Danko. I'm the program coordinator for the SOR grant.
Thank you. And I think that's Hunter at Trinity. All right, there might be some connection issues. And Sheena, would you like to introduce yourself?
I'm Sheena Sayers. I am the program manager for the SOR and STR MAT expansion.
Perfect, thank you. And Janice? Oh, you may be muted. Do you want to try one more time? And feel free to use the chat as well. And we have C. Simpson. Okay, and Amy Lively.
Amy Lively, care manager with the River Health Association.
Perfect, thank you. And Megan Toscano?
Hi, I'm Megan Toscano, the project assistant for the SOR grant.
Thank you. We have a number ending in 2360.
Yes, this is Mario Testani. I'm a medical director psychiatrist with the health plan.
Perfect, thank you. And a number ending in 3570.
Hi, Tina Harborwood, Northwood and Wheeling, therapist.
All right, perfect. Thank you, everyone, and welcome. So why don't we go ahead and get started? Dr. Zhang, anytime you're ready, I can pull up your didactic for you, and the floor is yours.
Yeah. I think I'm ready now because I prepared these slides for only 30 minutes, but you're welcome to ask me questions. I can, because we don't have any case to discuss today, so we might use the remaining time to discuss how COVID-19 affected our practice and what changes we have made at Chestnut Ridge. Probably Katie and Douglas can share with everybody. I think that's probably a good idea. Is that right, Katie and Douglas? Yeah. Hello?
Yes, my computer is on mute. I would be happy to talk about that afterwards, Dr. Zhang.
Yes. Yeah, I think that's very important. Yeah. So So today I'm going to talk about matching patients with substance use disorder to level of care, because this is a big deal. Because a lot of times, if you have 100 clinicians in the room, and we're talking about the patient's next level of care or even current treatment setting, then we may have 100 different kind of opinions. So what are the what is the standard of care? Because what is evidence based? So I'm going to share with you. I'm not an expert in this, but I've spent some time studying this. And in order for you to be an expert in a level of care, ASAM, American Society Addiction Medicine level of care expert, you have to receive training, and they even issue a certificate for that. So this is not only for basically the ASAM standard is designed for clinicians, and not only for for policy makers and for reimbursement purpose. So it's for everything. Okay. So how can I navigate to the next slide?
You can just let me know and I'll advance it for you.
Okay,
Is that okay?
Okay. Yes. Good. So this is my agenda. So first, I'm going to talk about the ASAM criteria for multidimensional assessment. So how are we going to assess patient, in order to place patients in the right level of care? So ASAM look at patients from different angles. So total 6 dimensions. And then we talk about the ASAM level of care. So basically we talk about all different kind of treatment settings. The ASAM has, I'm sorry about this. I don't know what happened. Okay, here. So ASAM has this standard, okay, standard level of care. They, there are different levels, 0 to 4, 5 different levels. Then I briefly mentioned some principles of matching patients to level of care. Placement dilemmas here, I pretty much deleted the slides because this lecture I usually give to fellows, but because we don't have much time to talk about this, mainly we're talking about a lot of times patient has safety concerns, and patient have different kind of individual issues we have to consider, and it's kind of it's a long topic. So the common implementation issues, because the ASAM has standards, but however, depends on the availability, depends on all different kinds of things, reimbursement policies, depends on state law, and all different kinds of things can affect our implementation. Now, finally, I would just briefly mention two studies about the validity of ASAM level of care. Okay, so just want to show you, yes, there's evidence. There's ASAM levels of care is kind of a valid right way to place patient. Yes. Next, please. So this is the 6 dimensions ASAM criteria. Look at. So the first one is the acute. I'm trying to see the whole. For whatever reason, I cannot see the top of the screen. But anyways, it's acute withdrawal and intoxication, so potential. So we talk about a patient with addiction problem. Then if the patient is acutely intoxicated, that patient needs a really acute, high level of care, there's no doubt. If the patient has been using benzo alcohol and patient is just stopped using and looking for help, so that patient needs to be detoxed, right? And even for opioids, if we want to switch patient to buprenorphine for MAT, so the patient may need to be detoxed from something else as well. So it's a complicated situation. So that's very important. But not only current intoxication or withdrawal symptoms or signs. Another thing is very important is patient's past history of withdrawal or intoxication could be very much related to current level of care, because if the patient has past history of withdrawal seizures, past history of talking about all different kinds of treatment in compliance, so we have to find a way to put a patient in a safe place. Okay, so that's one thing, that's acute intoxication and withdrawal. And the second is biomedical conditions and complications. Basically, here we look at a patient's medical condition. So if somebody has chronic condition like diabetes, hypertension, then that patient is more vulnerable. It's very likely to have medical complications. If patient has underlying like a traumatic brain injury or seizure history, then that patient very likely is going to have withdraw seizures as well. So in that case, then of course, that's going to affect the level of care comparing with a patient with no medical condition, pretty healthy, young, like adolescent, or just like 20 young people without any medical issues, preconditions. Then the third one is basically psychiatric condition. We're talking about emotional, behavioral, or cognitive functionality and complications. So if the patient has bipolar disorder, schizophrenia, and we know comorbidity of substance use disorder is so common, almost 50% in thought disorder population. So in that kind of case, then not only patient needs to be treated for talking about addiction, but also the psychiatrically the patient may need to be stabilized. So that's another thing we need to consider. So the third one is psychiatric condition. So the first one is withdrawal, intoxication. Second is general medical condition. The third one is psychiatric condition. Then the next three basically is patient's readiness to change. Is patient ready? One, patient has a goal to stop using, reduce using, or patient just want temporary relief. So then the relapse, continued use, or continued problem potential. So does this patient has high likelihood of relapse? This patient, has tried same treatment settings many times. Also, the recovery environment. Finally, so if we discharge a patient to a homeless shelter, or if we discharge patient to the same like a family. Actually, I have a patient whose uncle has been giving him drugs all the time, but he just each time we discharge him just back to the same place. So this is kind of a revolving door. The patient will never be able to stay sober. So all these three dimensions are very important in terms of patient's current assessment. Next, please. So this is level of care, ASAM, different levels of care. So 5 levels. The 0, of course, this is the early intervention, 0.5. This decimal points mean basically patient can have within the same level, like level 2, level 3, they may have different treatment settings. However, they may not, need to be moved to upper or lower level of care. So in the same level, we have different kind of, benchmarks here. So the earliest intervention is 0.5. Now we're going to talk about this in a little bit details in the next few slides. Then the level 1 is outpatient service. So actually our co-clinic is one of the outpatient services because this is a office-based buprenorphine MAT treatment for patients. So we see them like in outpatient setting, right? So we see them once a week, or sometimes we see them more often than that. So that's the outpatient setting. Then the next level 2 actually is intensive outpatient program or partial hospitalization service. In psychiatry, we have this day hospital program, which is partial hospitalization. This is a very ideal place for patients who does not need 24/7, inpatient treatment. But in the meantime, they have psychiatric condition. They may have like a severe addiction problem as well, and they need to be closely monitored at least like a few hours a day. So and then also in this level we have intensive outpatient program. So this is more like this patient spends more time in outpatient office with our therapists, with our clinicians, and then like a regular outpatient service. But then still, this is just outpatient. It depends on hours they spend with in the program. Then the next level is residential inpatient service. The residential program, of course, they have different levels as well. Then finally is basically it's medical unit, intensive unit. Yes, next please. So 0.5 ASAM, that's the lowest level. So this is early intervention for adults and adolescents as well. So this is a service for population at risk of developing substance-related problems. So those people, all for those people, still we don't have enough information to document a diagnosable substance use disorder. For those patients, we don't have enough information. We cannot say this patient has a substance use disorder, or maybe this patient is at high risk, but still does not, meet the criteria for substance use disorder. So this is the level of care we can give patient. This is not really a treatment. This is a kind of service. Yes, next, please. So level 1. Level 1 is outpatient service. So typically it's less than 9 hours of service every week. For adolescents, it's less than 6 hours. So we do a lot of motivational enhancement therapies, motivational treatment, and also we may give medications. Of course, it depends. right? Depends on what kind of drugs patients are using, and depends on what kind of what kind of stage. But no matter what, it could be a wide variety of settings. Because code is one of them, right? We can have regular, like a resident clinic. Also, we're talking about a counseling, like just regular counseling, or maybe once a week, maybe sometimes more than once a week, sometimes less than once a week. Those kind of clinics. Yes. Next, please. So level two basically is two kinds of programs. One is intensive outpatient program. So we have intensive outpatient service. So those people usually, they come to the clinic. Basically, the programs to kind of offers more than 9 hours for adults or more than 6 hours for adolescents every week. Okay, this, of course, we're talking about a multi-dimensional instability. Remember, we have six dimensions, right? Because we're talking about intensive outpatient program here at Chestnut Ridge. We have one. We see patients 3 times a week, Monday, Tuesday, and Thursday. So each time we see them about 1.5 to 2 hours. And actually Tuesday, I see them in a medical group. So some of them are on medications, some of them are not. Okay, some patients on buprenorphine MAT. So what I do is, in the meantime, this clinic should be able to, this kind of program should be able to offer treatment for co-occurring conditions. So I think a lot of insurance companies do not pay extra psychiatric appointment for patients who are actively involved in IOP, intensive outpatient program, because IOP is designed to be able to help patients with their psychiatric conditions as well. So in this clinic, I usually spend time with them. I still see them in group setting, and what I do is I usually help them manage their psychiatric medications as well. It's a little bit difficult because you don't really have enough time to spend with everybody. But on Tuesday, every Tuesday after my medical group, these 10 to 12 patients, usually they spend still together next hour in a family members. Anybody in the supportive system is kind of invited as well. They can participate in a family session. So that's great. So we can utilize whatever support patient can have. So of course, this is an organized outpatient service that delivers treatment services during the day, before and after work or school, in the evening, and also on weekends. This is good because our program is designed to be 12 weeks. We can talk about that later. But usually people, this is from after 4 p.m. So a lot of people they can after an acute treatment on DDU. So I discharge them to IOP, and they can work in the morning. Then they can come to the clinic. Yes. Next, please. So the next level is 2.5, which is partial hospitalization service, stay hospital. Usually it's more than 20 hours a week. Okay, this is usually those for people who are kind of having chronic mental illness. Okay, they have tried outpatient treatment, but they did not make any progress. Okay, but those people do not really require 24-hour care. So again, our day hospital should be able to meet the complex needs of people with addiction and co-occurring conditions. This is still outpatient service, but a patient comes to a hospital during daytime. It can be 3 times a day, or 3 times a week, or 5 times a week. Depends on patient's condition, and also sometimes depends on, unfortunately, depends on the reimbursement, the coverage policy. So patients usually spend from 8 to, I think it's about 4 hours a day. So it's from 8 to 12. Then they eat breakfast. They have groups. They have counseling groups. Sometimes they have individual therapy sessions. A lot of times they have a lot of psychosocial rehabilitation activities. Next, please. So this is level 3. Level 3 basically is residential services. Those are open treatment facilities. Okay, they're not locked, so patient can just walk in and out of the building. However, they live there, they stay there 24/7. So the residential service is supposed to be able to handle co-occurring conditions. Okay, they're supposed to have a team, the designated team for addiction treatment. So this is 24-hour treatment setting. We have all different kind of levels, sub-levels in this level 3. Okay, we're going to talk a little bit about that later. Yeah, next. 3.7. So this is the highest level of level 3. So basically, this is a medically monitored high intensity inpatient service. And or for adolescents or for adults, it's a medically monitored intensive inpatient service, withdrawal management. So the typical example is our Center for Hope and Healing Acute Detox Unit. So this is a 3.7 level of care. So basically, it is 24-hour nursing care, and also physician has to be there at least 5 days a week. Actually, on weekends, we also have physician availability. So physicians has to be there and to do medication management. However, patients, usually we're talking about dimensions 1, which is acute withdrawal and intoxication. Remember, dimension 2, which is medical condition, biomedical condition, and complication. And dimension 3, which is basically emotional and cognitive, and we're talking about psychiatric condition. So for those patients with some kind of psychiatric problem, however, they want to be off alcohol, benzo, whatever, and they need to be detoxed, but they do not have high risk for acute, we're talking about medical complications from withdrawal. So in that sense, a lot of times we just send them to this acute detox unit, 3.7 level. The good things, like we have residential 3.5 level residential treatment facility in the same building. So we can, once they do better, usually we smoothly transition them to next level of care. Yes. Okay, next slide, please. So usually patients require medication and have a recent history of withdrawal management at a less intensive level of care. Usually patient if the patient can be placed in a less intensive care, of course you want to do that first. But this kind of patient, usually they have high likelihood of withdrawal. Usually they have like a past and a current inability to complete the withdrawal management. And so they cannot be that compliant. In that case, we need to motivate them. So this is an appropriate setting for patients with subacute biomedical and emotional, behavioral, and cognitive problems that are so severe, but they require, so they have to be inpatient. However, in the meantime, they're not really that bad. They're not really that, talking about, they do not have very bad medical complications that need to be that closely monitored to be like we have 24/7 physician availability. Yes, next. So level 4 is like a typical DDU, dual diagnosis unit, the unit I'm running now at Chestnut Ridge. So this is a medically managed intensive inpatient service. So it offers 24/7 nursing care and daily physician care for severe unstable problems in ASAM dimensions 1, 2, 3. And counseling is available almost 16 hours a day to engage patients in treatment. So a lot of times we want a patient to be highly motivated. We want them to, actually, we require them, I hate to say that, but that's what we do. We require them to participate in groups during daytime and also evening times. We offer like 12-step meetings and different kind of peer support groups as well. Yes, next, please. So finally, we have ASAM has this OTP, opioid treatment program. Mainly, this is a methadone clinic. This is a daily or several times weekly, highly organized, we're talking about a medication and a counseling available, and to maintain multi-dimensional stability for those with opioid use disorder. Of course, it can be combined with any other program. For example, if the patient, we have like in our detox unit and our 3.7 level and also 3.5 level residential programs, some patients are on methadone clinic, so they still have to get methadone from OTP. So that's something which kind of, we can have both, not just it does not need to be one of them. Okay, next, please. So this is a summary of level of care, ASAM level of care. So the level 0.5 is early intervention, level 1 is outpatient, level 2 is intensive outpatient program, usually it's more than 9 hours a week, and the partial hospitalization is more than 20 hours a week. And level 3, of course, mainly is residential treatment programs. It has different levels, and some residential programs offer detox, some do not. Okay, that 3.1 usually is kind of those programs that sometimes they do not have like a physician availability on the 24/7 like nursing care. So in that case, then they may not feel comfortable to detox a patient. That's understandable. Then level 4 is medically managed intensive inpatient treatment. Usually you have 24/7 everything. So available, and then you have to offer like almost 16 hours, like talking about the different kind of treatment, counseling programs. Okay, so finally OTP and opioid treatment program. This is just mainly methadone clinic. Yes, next. So for withdrawal also, and the ASAM have different kind of levels. So like withdrawal management, level 1, level 2, level 3.2, 3.7, level 4. But anyways, so to make it simple, so the withdrawal level, the question is, do you feel comfortable to detox a patient in outpatient setting? It totally depends. But ASAM says basically if that person has mild withdrawal with but does not really need daily supervision. So in that case, the patient may be able to complete withdrawal management just at home. So if that patient has severe unstable withdrawal condition and that needs like 24-hour nursing care, of course you want to put that patient in the highest level of treatment, right? So this is the thing. A lot of times it's just that, it's hard to say, but this guideline gives us a good idea at least. Give us a guide, this is a guideline. It tells us what to do. We can always match patient with this, with this kind of assessment. This is very important because assessment is the key, right? Because for example, if I have a patient I have been seeing for many years, and I know the lady very well, and she has been on benzo Xanax 2 milligrams 3 times a day for years. And now it's time for me to get that person off Xanax. So the question is, should I admit the patient to DDU? But the patient doesn't want to. In the meantime, patient is motivated to come off Xanax. So in that case, how should I work with the patient? I have several successful cases. I just detox them like slowly, lowering the dose, and finally, in a few months' time, and I successfully got patient off Xanax. And the patient actually, they're very thankful because they're really much better. They realize, wow, I can be much better without Xanax. So that's it's individual cases. But for a person who's kind of opioid dependent now, using benzo now, they're asking you to do Ativan detox outpatient. Of course, I wouldn't feel comfortable with that. So it totally depends. Yeah, next slide, please. So this is just a summary. So basically, we screen the patients, then we make a diagnosis. Then the patient, we gauge the severity. Then of course, the patient's readiness and relapse potentials are very important in terms of patient treatment placement. So we assess patient from 6 dimensions. Okay, then we make this decision. If we use ASAM rule, then there's a software we can use. Okay, we can use rating. We can have a way to rate a patient in different dimensions. Then the severity. Then finally we place patients in the right level of care. So level 1 again, 1, 2, 3, 4. Right. Okay. Next. So this is just a summary of some kind of matching here. So for example, if the patient has no risk of intoxication or withdrawal, a patient has no medical complications, of course, the patient does not have any significant psychiatric condition. So in that case, the patient is cooperative. Patient is can be maintained very well. So in that case, we just see patient in outpatient setting. On the other end, so if the patient has severe risk of 24-hour acute withdrawal, then of course, then if patient has other medical complications, then where should I put the patient? Yeah, apparently it's the highest level, maybe just a 4.0 acute treatment place. Next, please. Okay, so again, this is very important to reconceptualize the definition of addiction. So nowadays, addiction, we know it is a medical illness. It's a chronic illness. So this is very important. It guides us in the placement of treatment patient, right? Because this is very important. The first sentence, remember, if I read this, then the first sentence basically is telling us addiction has multiple components. It has genetic component, okay? It also is related to patient's environment, okay? Life experience as well. Okay, so it has psychological component as well. The second sentence basically is talking about it's severe enough, it's chronic, and the patient has lost control. Even if they understand this is a harmful, disease, but they just cannot control. They become more and more compulsive. They have to use it to feel normal. Okay, negative reinforcement, all those kind of things. Another thing very important, in today's model is basically because of this, we understand, because of all those evidences, we understand addiction like diabetes, like hypertension, like many other chronic illness. So can be prevented and also can be treated. This is very important. So prevention efforts and the treatment approaches for addiction are generally very successful as well, as successful as those for other chronic conditions. Thank you. Next. So I'm going to talk about some basic principles in matching patients to the level of care. The first is every treatment plan has to be individualized. So when I say that this is hard because here we have MAT program, we have a code clinic. So we have rule, we have policies, but the patients are different. Keep in mind. So we need to offer patient-centered care, and the ongoing assessment is the key. So each time patient relapse, so the question is, what are we going to do? Yeah, we have rules, which is great, but in the meantime, so we have to do ongoing assessment. We have to identify triggers. We have to find out what's really going on, and we have to do a full evaluation of patient's goal. We have to evaluate the comprehensive bias, psychosocial condition, and also involve families and patient supportive system. And the length of service. If we link the length of service directly to patient's response to treatment, then that is right. However, a lot of times we have fixed length of treatment or program-driven treatment. They said, like, you have to, this is program you have to finish. This is very convenient and predictable for providers like us. But overall, they're less effective because every patient is different. There's no one-size treatment for addiction, and we know that. Next, please. So consider the patient as a whole person. Should we base treatment on diagnosis only? So everybody on opioid, everybody with opioid use disorder severe, they should be on buprenorphine MAT, but that's wrong. But some people are not really, they're not, Suboxone is not for everybody. We know that. Maybe some people you do need to use Subutex in certain situations. So the ASAM criteria takes multidimensional approach. So it recognizes the many different areas of patient's life, which is very important. We talk about 6 dimensions, remember that, including like psychosocial, we're talking about emotional, cognitive, all different kinds of things. So life areas, dimensions, right? And also the risks and needs and strengths and the weakness and resources. So our treatment, our placement should be based on those things. Next. So the next principle is very important. When we choose the treatment level, so the number one thing we have to keep in mind is patient should be in the least intensive level of care. So that means we have to meet the patient treatment goal. But in the meantime, we have to keep patients safe. Okay, so safety is almost the most important thing. But in the meantime, patient needs to be in the least intensive level. So that's very important. So a lot of times admission criteria is patient has to be motivated. So when I discharge patients to a 28-day program, then you can see the patient stays in the room all the time, doesn't want to come out, does not want to, maybe just crashing from meth use, or maybe from different reasons, and maybe not really motivated enough. The question is, if the patient has some interest in a 28-day program at residential, we're talking about level 3 treatment, should we send a patient there, or patient has to be motivated enough? That's a big debate, usually among our staff all the time. But anyways, the real admission criteria is very simple. Should be just the patient's willingness to enter a treatment. So our job as clinicians, actually, is to facilitate patient self-change process, right? Along the stages of change using motivational enhancement strategies. When I say that, it's basically, what I mean is, yeah, a patient may not be motivated enough. That's why the patient needs this kind of treatment. That's why the patient needs this level of care. So that's our job to motivate the patient. Okay, next. So another thing is continuum care, which is very important. Okay, the good thing about our Center for Hope and Healing is now we can smoothly transfer patient from DDU to detox unit sometimes, or maybe directly to Center for Hope and Healing, then directly to day hospital or IOP program with sober living. So I personally have experience since the opening of our Center for Hope and Healing. A lot of patients have definitely made significant progress just because of this seamless transfer between levels of care. I believe Katie and Douglas probably will agree with me. Actually, my readmission rate in the past few months since the Center for Hope and Healing opened has dramatically changed for a lot of patients. So ideally, we should admit patients through the programs, not just the 2A program. So there's we're talking about philosophical congruence among the various providers are very, very important. If I send a patient to a 28-day program, and that patient is that program is basically kind of whatever based, and the providers over there just stopped patients every medication, including Prozac. Now I do not think the patient can get the best level of care, high quality of care, and also the timely arrival of a clinical record. That's also a key in the continuity of care. Yes, next please. So we have to continuously assess patients. Okay, if the patient relapses during the treatment, automatic discharge, administrative discharge the patient may not be the right thing. It depends. It depends. If patient, it depends, right? The patient is aggressive towards staff member. A patient may, is making threats to other people or providers. Then in that case, I think that's understandable. But if they just relapse, so the question is, what are we supposed to do? We have to reassess. So assessment. We have to revise our treatment plan. So that's probably that's at least the ASAM recommended. Yes, next. So treatment failure. So the common things about treatment failure is a lot of times we say, well, the patient was not ready. The reason patient failed, we say patient fails at one level of care is because he's not ready. So have we ever thought about, we did not provide what the patient needs. We only provided what we wanted to provide. So that could be a problem. A lot of times I think it over and over. So we as physicians or as therapists, as clinical and healthcare providers, what we do here, a lot of times we provide what we are able to provide. We provide what we know, but it may not be what a patient needs at the moment. So another thing is failure at one level of care as a prerequisite for approving admission to another level of care is not recommended. For example, some programs say you have to fail day hospital program. You have to fail your 12-week intensive outpatient program in order for us to admit you to our residential program. That's definitely not a good care. Okay. Another thing is, since we agree that nowadays addiction is a chronic disease, chronic medical illness, the complete cure and elimination of the problems is not our goal. So it can be achieved. So our real goal is a reduction in intensity or severity of the symptoms, duration and frequency of symptoms. So a lot of times, even in our code clinic, the patient has reduced the amount of use, has been using less frequently. Look at your patient's records, but seriously, talk to your patients. So how many times your patient relapsed on heroin or other opioids while they're on Suboxone? Very, very rare, at least from my experience. The peak time I had like 150 patients in my clinic. I never had, I mean, very rarely I have, you know, I had a patient relapse on heroin or something else. So unless you didn't dose it right. So that's the key. So I would say, yes, we're providing good care to patients in some sense. Maybe we need improvement, of course, but reduction in intensity or severity of symptoms is a realistic goal. Okay, next. So common implementation issues. So we have program-driven model. Again, I just want to give you some examples, like a 30-day inpatient program, like 28-day inpatient program, 24-session IOP. No, the patient may need 26 sessions, may need like 30 sessions. It totally depends. An extended residential program. If you finish 28 days, we extend you for 2 weeks. And patient graduate, complete the program. Apparently, that's not really a good word to use. Well, I guess when I say patient graduate from weekly clinic, probably it's a good idea. But a lot of times, you know, think about this. It's chronic disease that do not graduate from a treatment program. Actually, this is just the beginning of the treatment. So waiting lists, admission criteria is imminent danger, all those kind of things are discouraged, not really right things to do. And states fund only a few levels of care. That's a big problem, especially in our state. And some insurance companies, especially PIA, as a WVU faculty member, if you have addiction problem, you can help. In the whole West Virginia, you can be admitted to only one residential program. So that's definitely not right. So levels of withdrawal management available are only, we're talking about, they just fix this. They say, okay, it's only available for whatever. Then you have to put, a lot of times patients come to emergency room, then they have to be sent to a detox unit instead of DDU because the insurance company doesn't pay for it. So that's not really good. And we are human beings. I think the guidelines are guidelines. It's good. We have numbers. We even have software. We can just create a number of level of care. But again, and we have to be also, we have to be flexible as well. Next, please. So exceptions to the patient placement criteria is one is lack of availability. For example, we understand that, right? Because in this, in this state, we definitely we're shorthanded. We do not have enough resources, and the failure of a patient to progress at a given level of care, and that happens a lot. I have patients who has been hospitalized. We're talking about probably like 20 times a year. And in that kind of case, then what are we supposed to do? We need to be creative as well. A state law requirement. Unfortunately, we have to follow. Unique clinical presentations or extenuating circumstances. Give you one example. I have a patient who has speech impediment, also has some kind of hearing problem deficit. So the problem is like, and that person is an opioid user, and she now is in our fellows clinic, and she's doing very well. So we only see her like once every 2 weeks. She has made significant progress. But in the meantime, like if we just put her in the regular co-clinic, I'm 100% sure she won't, succeed. Okay, next. So very quick, I'm gonna spend a couple of minutes talking about 2 studies. So research data. So how can you compare? How can you say this ASAM criteria or this matching algorithm works? So basically, you have to follow up patients, right? At certain time points, talking about to see whether they drop out, then 1 month, 3 months, 6 months, a year. Then you compare ASAM criteria with some other kind of placement approaches. For example, a lot of times it's clinician-based. We just basically based on availability, based on a addiction severity index score, right? Then you have different ways to evaluate, to make assessment, of course. And then outcomes, of course, you can look at all different kinds of things. And usually all those studies, basically they look at initial engagement, retention rate, substance use, relapse, talking about morbidity, functionality, and the service utilization. Okay, readmission to the hospital like that. Okay, next. So this is the one study. They studied like 2,429 patients, total 79 addiction treatment programs in the United States. So naturalistic placement recommendations. They use basically they compared they calculate the score, then they use the computer software to generate the ASAM, basically ASAM matching place. So then they compare with the real naturalistic placement. So they found, in conclusion, they found that those people who were undertreated, undermatched. So if there's an ASAM score, ASAM criteria basically recommends, let's say level 3, but if the patient was sent to like level 2, then usually the outcome is worse. But overmatching is really inconsistent. Actually, overmatching, we send patients to high level of care than ASAM recommendation. Then a lot of studies, it's kind of very inconsistent. This study also showed an inconsistent result. Okay, next, last slide. Yes, so finally, this is a Norwegian study, and it's a prospective, double-blind, multi-site 2012 study, and total 10 sites, naturalistic design, total 261 patients, so 3 counties, baseline interview, and 3-month follow-up. So they look at different kinds of things, mainly dropout rate at 3 months' time, drug use frequency, and addiction severity index score change, and recommended level of care and follow-up. Okay, last slide, 2 graphs. Yes. So basically, look at this. So in the middle is really matched by ASAM. Then the left is undermatched. Right is overmatched. So the first is dropout rate at 3 months. You can see the undermatched definitely has a higher dropout rate. The overmatched, of course, you overmatch your patient in a high level of care, then you can understand the dropouts, it's kind of, it's lower in this case. So, but anyways, in this case, you matched, you match the patients have 30% better show rate. This is very important. And then finally, talking about the addiction severity index subscales, it's total like 7 subscales improvement at a follow-up 3 months. You can see matched, ASAM matched placement. They definitely can yield way better outcomes. So this patient, that means the patient made good progress in terms of the addiction severity, right? Okay, that's it. Next slide is my references. I spent 40 minutes.
That was excellent. Thank you so much.
Thank you.
Ask everyone, were there any questions for Dr. Zhang?
Yeah. Okay, so what can we do though in terms of advocacy and getting things changed and getting more options for our patients? Because we know we're lacking, but like, for example, I have no idea what to do about going about in terms of advocacy.
So I think we need to work together. So here we have a list of programs. We have actually they send me an Excel sheet of all available residential programs or different kinds of things. So we need to work together for the whole state because we have only limited resources here. So how can we smoothly make transitions? And if we have availability, we have I thought about this. We should probably we can talk more about it, to design an online program so we can just easily check the next available place, and also we can hopefully longitudinally follow up the patient's progress, then try to figure out where, for example, if I discharge a patient from DDU, then Center for Hope and Healing has no opening at this time, but patient has been referred to many other places. So how many more places should I refer patient to, or how many? The problem, other things like application form, like every program is different. Now it takes hours for our discharge planner to fill just one application. So how can we have only one discharge planner for 12 patients? So how many programs can I refer patient to? So this is all these kind of things. If we can work together, also including like a code clinic. So if we have we have a network here, I think this works well. This ECHO project, this is MAT, because we now I have many times I have patients discharged to different programs at different places. So in this network, talking about in this ECHO network, so it worked. Especially I think what's that place? Kaiser area. So we know where patient can go. So this is wonderful. So this is I think it's a team effort. Together we might be able to make some changes. Yeah.
Yeah, because we get that report from Keith, the RASS, and it's sent from Cynthia Parsons, right? But we actually have called those programs many times, and a lot of them don't accept MAT. Even though, according to her, they do. If you actually call the actual program, nope, it's a lot of red tape. So I like your idea about working together, because maybe if we can figure out which programs actually do accept people and are more readily accessible, instead of just calling 60, well, it's not 60, but you know what I mean? We just call the ones we know that actually do things.
Yes, absolutely. Yeah, makes perfect sense.
Any other questions? Feel free to chat in any questions and I can ask them for you as well.
This is Mario Testani. Can you hear me?
Yes.
Yeah. So, yeah, I just want to underscore what the last comment and then add to it. There seems to be, because I am involved in programs around the country. And there's something unique about this area in programs not accepting patients with MAT. It seems to be an archaic attitude about the use of MAT to treat addicts, as if it's somehow cleaner to treat them without MAT, and it defies, all the scientific literature on how effective MAT is in certain kinds of conditions. So one of the things I think that we need to do in working together is an outreach to programs that don't seem to understand the state of the art of medical science in treating addictions. So that's just a comment. With regard to more of a question, you made reference to 28-day programs and how overtreating, logically overtreating is going to run into fewer relapses than undertreating people. But we also have limited resources, and it's hard to use blanket overtreatment, and because it means that some people are going to be excluded because some people are being overtreated who are not making use of the programs, whereas others who would make better use are not getting in because the beds are occupied.
Right.
And so what suggestions do you have for how to make best use of those programs? One of the things I notice is that if a program identifies itself as a 28-day program, for instance, there seems to be a lack of urgency. They don't think the first 7 days is as critical as the last 7 days because they have 28 more days, they got 23 more weeks to go. But actually every day is critical, and we need a way to measure what we're doing on a frequent basis and to be able to have valid measurements of some clinical whatever, and revise treatment plans ongoing to make best use of the time, and then not necessarily adhere to a 28-day program. Some people might either demonstrate improvement for step down before those 28 days are up. Others may show that they're not really going to make progress and they should be discharged and make room for someone who's going to make use of the time.
Yes.
And that I think motivational interviewing maybe is a factor that should be used at day one with some measurement of its suitability and potential effectiveness in each individual case. Otherwise, we're just doing a priori procrastinating 28 days, and we're not distinguishing who's making use of those days.
Yes.
And any comment on that and what you would suggest?
I definitely agree with you 100%, because one thing I learned is basically the continuum care is so important. 28 days, no matter what, it's just 28 days. So actually, I always tell patients, actually 28 days is just the beginning of the treatment. It's not really a treatment. So it is a treatment, but it's just the beginning of the treatment. So what I found, like those people who really, benefited from 28-day programs, that's what I'm trying to, because our 28-day program, Center for Hope and Healing, is run by Dr. Farmer. Dr. Farmer is our first fellow, addiction medicine fellow. He's a family doc, and he's so now it's the good thing is like we are from the same program, so we have the same training, so basically we understand this is what's important was the thing to do even from day one. So the smooth transition and also continuum care is so important. Those people who really do well at least from my experiences, they do DDU first. They acutely detox. Okay, then they think about basically we refer them to 28-day Center for Hope and Healing. Then they go to a sober living house in Morgantown. Then they also come to why are they in Morgantown sober living place? We have several sober living houses here in Morgantown. Then they attend our intensive outpatient program. Of course, that is a level 2. Or they may just go to like level 2, like the day hospital program. So that 12 weeks really, is kind of very good after residential treatment, which is very important. So I think most people who agree to do this 12 weeks, I said 12 weeks is fixed, but it can always be like extended, depends on the situation. So 12 weeks of IOP, they really do much better. So that's that's what I think. I totally agree with you. From day one, they need to think about the whole thing, not only just the next 28 days. They need to think about what they need to do. I mean, after 28 days, if they start looking for looking for resources, support, if they start thinking about the stable place and a supportive place to live. In the meantime, active involvement in treatment, those people tend to do much better. Yes.
Yeah, I mean, I would go further. I would say eliminate the concept of a 28-day program.
Mm-hmm.
And every program has to try to work effectively and efficiently so we make the best use of resources.
Right.
Early on, someone may show progress and benefit from more time. It should be continued. Others maybe need to step into a different, because they're not making good use of it, and there are other people who would take their place. If we get to whatever day, 21 or 28, those that need more get more, but many people will have needed less and have made room for other patients. The idea of a 28-day program is Procrustean. It's like one size fits all. We need to stop thinking that way, I think.
Yes, I think that's what ASAM recommend. Yes.
Yeah.
I think a lot of providers do think that way. The problem is just the reimbursement, right? Because the people who work in 28-day programs know, hey, this person will benefit from another 4 weeks, or this person is ready now. But according to the insurance providers, they will not pay more than that program. So I think we have to kind of tackle insurance and try and make some laws.
Well, I represent insurance actually, and that's not really. I understand that's the experience often. There are many different insurance companies and MCOs, but I represent the health plan, and our objective is medical necessity. And we're happy to authorize more if somebody can document and demonstrate why more is needed and why more would help. Not only is it needed, but what you're going to do to actually make a difference. And then we'll authorize more. But we want the other side of the equation also. We want you to look at who's not benefiting or who has benefited enough and can move on, rather than keeping them the full 28 days because that's what the authorization is. It goes both ways. We both want to manage the community resources effectively. And so some people need less and some people need more, and we should base that on the case. And that's our philosophy, and that's how I do my reviews.
I think I'm glad, Michael. I'm glad you're here and you say that, because it's learning for me as well. Basically how to help patients get covered. So I think that's very important. Yeah, what is going to really benefit patients? Then we need to think about that. Yes.
Right.
Well, we have a couple questions in. I know one of them was briefly answered, but one was, how are 28-day programs paid for by insurance? Is it daily or more like acute care hospitals? Thank you, Dr. Bell, for responding to that. Depends on insurance. And then another one, does insurance pay for sober living sites? So I just wanted to throw those two out there.
Not as I know. I don't think insurance. I don't know any insurance that can cover a sober living house. But what's important is the sober living house. For example, Morgantown Sober Living House or Oxford. And basically here I'm talking about locally. They facilitate patient to job-seeking behavior. They help patient to they help patient work with companies to help patient for job placement. So usually, and it's very helpful. Yes.
Perfect, thank you. We do have just 1 minute left. This has been an excellent session, as is all of the other ones. If there are any further questions, feel free to email them to me. I'll make sure they are addressed and I'll send them back to you. Just one quick announcement. Our next session will be on April 27th, and Tony DiCiocchio is providing our didactic on best practices. So keep an eye out for that. We'll be sending out reminders. Thank you so much, Dr. Zhang, for that excellent didactic, and thank you everyone for joining us. We'll see you guys next time. Stay safe.
Thanks, Dr. Zhang.
Thank you.